Hi, my name is Stacy Cardillo. I am a student at the University of South Florida in the College of Nursing. I am in the FNP track, and I'm currently in the Advanced Physiology and Pathophysiology course. This is my case study on a patient with dyspnea. So here I have an outline of the topics I'll be discussing for the case study. We're going to start with some patient information, and then we'll be ending with teaching and guidance. There'll be some smaller concepts within each of these topics along the way. So here we have some information about our patient. Demographics include she is a 61-year-old female, Caucasian. She is a current middle school teacher. She's married with 3 children. Some family history: her mother died at 82 from colon cancer, and her father is still alive with a history of myocardial infarction and AFib. Her medical history and medications include she doesn't have any allergies that she knows of. She is currently on 10 milligrams of amlodipine and 5 milligrams of lisinopril daily for her hypertension. She is obese with a BMI of 34. She considers herself an occasional drinker. She drinks 2 to 3 glasses of wine a week. She does have a history of smoking, 1 pack per day, and stopped 15 years ago. Her surgical history includes C-section and tonsillectomy over 20 years ago. So our patient's chief complaint: she says, "I've been feeling so short of breath whenever I have to walk up the stairs at school. It's been getting worse the last couple of months." Other complaints include, shortness of breath with routine activities, worse with exertion. She's very fatigued. She's noticing some swelling around her ankles during the day, and then she says it goes away by the morning. She also reports a 3-pound weight gain in the last week. So here we have our review of symptoms and physical exam. Our patient is moderately obese, but otherwise healthy appearing. She's mildly short of breath when she walks into the exam room. She's completely alert and oriented. She's got a regular rate and rhythm with an S1, S2 heard. No murmurs or rubs. We do notice some jugular venous distension. She denies any headache or dizziness. She's mildly short of breath, as we can see, and on auscultation of the lungs, we hear some fine crackles on the lower bases. No GI or GU complaints. Her abdomen is obese and she's got normal bowel sounds. She's got normal skin color. We notice some +1 pitting edema to her bilateral lower extremities, and her vital signs are relatively normal. Respiratory rate's a little high at 22, and her blood pressure is a little high at 140/86. Our differential diagnosis in order of priority: we're starting with myocardial infarction. With women, they can have nonspecific symptoms of MI, such as those reported by our patient, which leads us to want to prioritize the ruling out of an acute MI initially. So once that's ruled out, we're left with a possibility of diagnosis with cardiomyopathy, heart failure, valvular disease, and lung disease. I came up with this differential in a combination from the American College of Cardiology and the UpToDate resource. Laboratory and diagnostic studies. So in any care setting, we would want to rule out the priority differential diagnosis starting with MI. Our ability to get certain labs and imaging will be different depending on the setting, whether it be acute care or an outpatient care setting. For the sake of this case study, we'll be in perfect world circumstance and we're able to get any labs, any imaging, and we'll receive those results in a very timely manner. So for her labs, her troponins ×2 were both negative. Her BNP was elevated at 258. We also got a CMP, a fasting lipid profile, and CBC. All these results were within normal limits. Her EKG showed normal sinus rhythm at 98 with no ST abnormalities and a left axis deviation. Her chest x-ray showed mild cardiomegaly and pulmonary vascular congestion. Her echo showed left ventricular ejection fraction of 55%, mild left ventricular hypertrophy, and mild left atrial enlargement. It also showed filling pressure of estimated 11. So with these results, the chest x-ray and the echo, we went ahead and rolled out the remaining diagnoses. And with the universal definition of heart failure being symptoms or signs of heart failure caused by structural or functional cardiac abnormalities in at least one of either elevated natriuretic peptides or objective evidence of cardiogenic pulmonary or systemic congestion. And then it's further categorized into heart failure with preserved EF with an EF of greater than 50%. And we see here by the echo results, our patient fits the diagnosis of preserved ejection fraction heart failure with the cardiac structural changes and her EF of 55%. So the diagnosis of heart failure with preserved EF is actually globally challenging in early stages. Symptoms can be nonspecific and can match a range of different diseases. So there are a couple of diagnostic scoring systems available. I retrieved those from Reddy et al. 2018. So our patient history contains 3 out of the 6 points here and 5 out of the 6 total with inclusion of the total filling pressure. On the chart, following the recommended scoring, we would need to get the additional testing of BNP to confirm diagnosis. And then if diagnosis still isn't confirmed, of course, we'd be consulting cardiology. We would need to retrieve some invasive hemodynamic measurements to confirm diagnosis. So going over the pathophysiology of contributing factors, hypertension is the most important cause. Prevalence is up to 89%. That's retrieved from American College of Cardiology. Hypertension is the main contributor of structural abnormalities that cause this disease. Obesity is one of the largest factors. Over 80% of those with the disease are obese or overweight. Increased adipose tissue promotes systemic inflammation, impairs diastolic, systolic, arterial, and exercise tolerance. Point 3, greater than 60 years of age. It's one of the criteria for diagnosis on the list. Aging affects mostly all components of heart failure. Age related to stiffening of vasculature, impaired calcium uptake regulation, decline in neurohormonal signals, physical deconditioning, and frailty. Collectively, these comorbidities will cause systemic inflammation that leads to endothelial dysfunction. It releases reactive oxygen species and reduces nitric oxide. This begins a cycle that leads to stiffness, fibrosis, and hypertrophy of the cardiomyocytes responsible for disease. And point 4, just to compare to our pediatric population, heart failure is rare and occurs without any systemic comorbidities as in adults. It's categorized into congenital, which includes dilated, hypertrophic, or restrictive cardiomyopathy, usually with a genetic factor, or it's acquired, like aortic coarctation, myocarditis, Kawasaki's, and multisystem inflammatory syndrome in children, and that was retrieved from Quenelin Bonnet. Here we're going to connect the patient's clinical manifestations to the pathophysiology components of heart failure with preserved ejection fraction. So in the beginning, hypertension over time causes a higher afterload in the heart. The left ventricle then compensates by working harder to pump that larger volume out, and that leads to hypertrophy. So at this point, the left ventricle's ability to relax and fill during diastole is impaired due to that stiffness from the hypertrophy and fibrosis. This causes thickened walls and smaller chamber size, and then this leads to elevated filling pressure. Over time, the chronic or intermittent elevation in the left ventricle filling pressure causes elevated pressure in the left atrium. And then this causes remodeling, which is an increase in size and in dysfunction of the left atrium. So then the downstream effects of the LV dysfunction causing the LA dysfunction leads to backup of the pulmonary vein, and then this causes congestion of the pulmonary system, which leads to dyspnea, pulmonary congestion, jugular venous distension, and fatigue. So then the left ventricle dysfunction also causes a decrease in cardiac output. This then causes a decrease in peripheral and organ blood flow. This mechanism causes a trick in the system to believe there is an issue with hypovolemia. So then at this point, the neurohormonal systems, which is the sympathetic nervous system, and then the renin-angiotensin-aldosterone system, are then activated to promote fluid and sodium retention, as shown by her elevated BNP. This mechanism can lead to peripheral edema, weight gain, and further promote pulmonary congestion and dyspnea. So, in an additional study that I looked at, heart failure with preserved EF may also cause microvascular and lymphatic abnormalities from an increase in venous pressure. In this mechanism, hydrostatic pressure is increased, which drives excess fluid out of the vessels into the interstitial spaces. Impaired lymphatics are then unable to clear this overflow, which results in visible fluid accumulation in dependent parts of the body, like the legs and ankles, and those parts of the body have lower venous pressures. That information was retrieved from Roseto et al. 2020. Treatment and management. So, management occurs across the healthcare system for patients with heart failure. There's obvious differences in treatment of acute decompensated heart failure and stable heart failure with preserved EF that's diagnosed in an outpatient setting. For this study, we'll be focusing on the management in the outpatient primary care setting. So treatment is geared towards symptom management, preventing disease progression, and improving quality of life. The 2023 ACC-AHA guideline recommends maintaining systolic blood pressure less than 130 with medication titration and hypertension in the patients with the heart failure with preserved EF. In most recent studies, the sodium glucose cotransporter 2 inhibitors is now a first-line recommended treatment for patients with heart failure, regardless of ejection fraction. So the studies that were done specifically for patients with preserved ejection fraction showed a decreased risk of worsening heart failure and cardiovascular death and improved quality of life. Risk factors should always be assessed in each patient when starting a new medication. And our patient for this case study doesn't have any of the contraindicated comorbidities for starting an SGLT2I. So we would likely start her on one of those. Other medications would be to treat her congestion, edema, blood pressure treatment with loop diuretics, ARBs, and ARNIs. And then another part of the ACC treatment guideline would be to start an MRA if diuretics and the SGLT2I doesn't provide optimal therapy. For a non-pharmacologic treatment, the main points are, lifestyle changes, exercise, weight loss, the DASH diet, which includes sodium restriction, as well as calorie restriction. For calorie restriction, there was a recent study by Kitzman et al. It showed that calorie restriction-related weight loss improved exercise capacity, and it improved heart failure-specific quality of life measures in older obese patients with chronic heart failure with preserved EF. A sleep medicine consult was also mentioned in many of the studies. A lot of the symptoms that patients with obstructive sleep apnea can be similar to patients with heart failure with preserved EF. So it would be good to rule out obstructive sleep apnea and hopefully improve maybe some of the fatigue and other symptoms that they're experiencing. And here's just a diagram taken from the American College of Cardiology that showed the guided medical management for the heart failure with preserved EF treatment, starting with the HGLT2Is. So prognosis and expected healthcare outcomes. Hospitalization for heart failure signals worse prognosis. Nearly 40% of heart failure with preserved EF patients die within 5 years following discharge from hospital for heart failure. That kind of highlights the importance of prevention management in the outpatient setting and keeping our patients out of the hospital. Comorbidities including obesity, hypertension, diabetes significantly influence prognosis. And then predictors of mortality and poor prognosis in patients with heart failure with preserved EF include older age, male sex, New York Heart Association classes 3 or 4, coronary artery disease, peripheral artery disease, diabetes, renal impairment, pulmonary hypertension, right ventricular dysfunction, and AFib. The NYHA heart failure classifications go through from C1 through C4. The beginning stage has no activity limitations, and then C4 is the worst, and there's discomfort in all physical activity and with symptoms at rest. And then for cultural and socio-cultural considerations, patients with heart failure come from diverse backgrounds that may have certain socioeconomic disadvantages, language barriers, and unequal access to care. Healthcare providers should recognize these barriers and adapt care plans to meet the needs of each patient, consult assistance of case management, and social work as needed. Cultural values can influence decision making and perceptions of heart failure diagnosis. And then education sessions should be adjusted to each patient's health literacy. Health literacy can range drastically. Healthcare providers should ensure effective communication, and they should use layman's terms and interpreters whenever possible to ensure patients understand their plan of care and maintain respect of patient culture. So teaching and anticipatory guidance. First point is dietary and medical noncompliance are the most common reasons for hospital readmission in patients with heart failure. Our patients should really be educated and encouraged to make improvements in their lifestyle factors that can help improve their heart failure symptoms. There's a lot of studies that showed weight loss, dietary improvements can really resolve a lot of their exercise intolerance and fatigue. Second point is that uncontrolled blood pressure has been linked to acute heart failure decompensation. So control of hypertension is very important. It can prevent heart failure with preserved EF. Priority teaching should include the importance of medication compliance and blood pressure control. Third point is that symptom control is very challenging despite conventional medical therapy. So a lot of the times there's inadequate control of symptoms in severe heart failure. So palliative supportive care evaluation should be considered to assist patients in prognosis estimation, anticipatory guidance on available therapies, optimizing quality of life, and anticipation, prevention, and treatment of suffering. Palliative consult is actually a class 1 recommendation on the ACC guidelines. It should ideally be considered and provided at the onset of symptoms. And this should obviously be done very cautiously, as palliative care is commonly and inaccurately associated with the hospice care, so there can be a lot of back and forth with initiating that kind of help.